Welcome everyone, so glad you're joining us for this explainer. Today we're bridging the gap between textbook theory and real-world clinical application with an absolute masterclass on peripheral fundus examination. You know, if you're an eye care professional or student, you've probably had it hammered into you that what you can't see can absolutely hurt your patient. So today we're going to master the advanced visual tools required to make sure we leave zero clinical blind spots behind.
Right. Let's just take a quick look at our roadmap. We're starting with what lies beyond the central retina. Then we'll master the head-mounted BIO, move into the slit lamp contact lens, take a really deep dive into scleral indentation, and finally, wrap things up with some absolutely crucial clinical safety practices. Okay, Section 1. Beyond the central retina, and really, what are you missing? We're jumping right in with a pretty high-stakes clinical vulnerability. That serious fear of missing out on vision-threatening peripheral lesions. Think about it. If you're relying entirely on general central fundus techniques, you seriously have to ask yourself, what dangerous pathologies are lurking just out of sight, right past the equator of the eye? Honestly, it's a bit like only inspecting the lobby of a building while the roof might literally be caving in.
Let's contrast standard direct ophthalmoscopy with some of these advanced peripheral techniques. Direct ophthalmoscopy gives you this tiny, highly magnified static field of about 5 degrees, which barely even gets you to the equator. But when you switch to peripheral tools like the head-mounted BIO, you unlock an incredible 45-degree static field. That is a massive jump, and it allows you to dynamically examine the entire retinal surface.
When you visually map this out, it's wild to think about the sheer amount of unseen retinal real estate you're dealing with. If you picture the boundaries of those standard methods, everything beyond that outer edge is just completely invisible to you. Well, invisible until you apply the techniques we're about to cover, that is. Moving on to Section 2, Head-Mounted BIO Mastery, our standard clinical workhorse. So, the head-mounted binocular indirect ophthalmoscope, or BIO, is really our first essential tool for eliminating those blind spots. It gives you a brilliant stereoscopic wide-angled view. But you have to remember the physics of what you're actually looking at. The aerial image produced with that plus 20 diopter lens is real, magnified, inverted, and laterally reversed. Basically, up is down and left is right. You literally have to train your brain to remap this image on the fly. The headset unit itself is absolutely vital for getting a dynamic, high-resolution view of the far periphery. I know, it looks a little medieval when you first put it on, but trust me, once you master the mechanics, it truly becomes an extension of your own eyes. Let's actually walk through exactly how to set this up physically. First, you place the unit on your head and tighten that headband until it's perfectly secure. Then, swing the housing unit down and meticulously adjust the eyepieces. You want to match your exact PD, your interpupillary distance, because that's what guarantees your stereoscopic view. Finally, adjust the mirror vertically and make sure you match the illumination size to your patient's pupil size. That's going to save them from a lot of unnecessary glare. And then you have the magic wand that pulls it all together, the plus 20D aspheric condensing lens. The trick here is introducing the lens close to the patient's eye and always double-check that the silver edge of the lens casing is facing them, and then smoothly pull it away towards yourself. You just stop pulling back the moment the red reflex fully fills the entire lens area. Boom, beautifully magnified fundus detail. To nail this exam, you've got to keep the headset unit at roughly arm's length from your condensing lens. And the real power of this technique? It's dynamic. You direct your patient's gaze into all 8 cardinal directions. Just methodically examine each quadrant until that full 360-degree retinal surface is completely mapped out.
All right, Section 3, the slit lamp contact lens technique, which gives us a true specialist view.
So we're stepping up from the wide-angle sweep of the BIO to a highly magnified, super-targeted assessment using slit lamp biomicroscopy paired with a multi-mirror contact fundus lens. Let's compare the optics for a second. While the BIO gives you a real inverted image with a massive field of view, this contact lens technique provides a virtual, erect, but reversed image. Yeah, it has a much more limited field, but the magnification and the stereopsis are just unparalleled when you need to pinpoint very specific anomalies. Now, because you're making direct physical contact with the cornea here, prep is everything. You must first apply a local anesthetic, followed by a viscous coupling solution right onto the lens. That prevents corneal abrasions and ensures perfect optical clarity. Once it's on the eye, the absolute golden rule is this:
Rotate the lens so your desired mirror is positioned exactly 180 degrees away from your target area of interest.
Once you've got that lens rotated correctly, you direct your slit lamp beam right into the mirror of choice. What happens is you're essentially bouncing your line of sight straight into the deepest, hardest-to-reach corners of the peripheral retina. The central viewing zone and those precisely angled mirrors just work together flawlessly to achieve that view.
Okay, Section 4. Our deep dive into scleral indentation, which is, without a doubt, the ultimate dynamic skill.
We have officially arrived at the absolute pinnacle of peripheral examination. Seriously, this is the skill that separates the novices from the master clinicians. Scleral indentation transforms what is usually a static observation into a truly dynamic assessment. By applying very gentle pressure to the outside of the eye, you're physically bringing the far peripheral retina right up into your field of view. You're revealing hidden contours, you're flattening out folds, and you're hunting down those elusive hidden tears.
Now, obviously, you aren't going to do this on every single patient who walks through the door. You deploy this tool for specific, high-stakes indications. We're talking about investigating far peripheral lesions in symptomatic patients. Or maybe you spot Schaefer's sign, tobacco dust, in the anterior vitreous. You'll also use it to localize hidden breaks during a vitreous hemorrhage, to monitor anyone with a history of retinal detachment, and it's fantastic for screening your high myopia patients.
Want some insider clinical wisdom for pulling this off smoothly? First, recline your patient completely into a supine position. Then comes the part that feels a bit counterintuitive. You actually ask them to look away from the exact area you want to examine. Why? Because it lets you safely place the tip of the indenter absolutely flush on the fold of the eyelid. Only once it's in position do you instruct them to direct their gaze toward the indenter. In practice, you're looking through your bio while performing this gentle indentation through the eyelid. And the absolute key here, the thing you have to practice, is maintaining correct, consistent pressure without ever putting direct, forceful pressure on the globe itself. You are rolling the tissue inward. You are definitely not poking the eye.
And finally, Section 5. Crucial clinical safety practices, because protecting the patient is paramount.
We really must ground all of these incredible high-level diagnostic skills with some very strict clinical safety boundaries. Your patient's well-being always comes first. Let's talk optical limits first. Adhere strictly to the ANSI recommendations. You want your instrument rheostats at half power and never ever exceed 40 seconds of continuous viewing on a single retinal area. We want to completely avoid phototoxicity. Next up, pharmacology. When you use mydriatics for dilation, things like tropicamide 0.5% or phenylene 2.5%, you absolutely must check intraocular pressures both before and after dilation, and finally those ocular anesthetics. We rely on them, but remember, they are highly toxic to the corneal epithelium, they need to be refrigerated, you use them very sparingly, and you must meticulously record the dosage, the exact batch number, and the expiry date right in the patient's record. No shortcuts there.
And with that, we've reached the end of our masterclass. The whole clinical fear of missing out on critical vision-threatening pathology, that ends for you today. Because with the BIO, your slit lamp fundus lenses, and scleral indentation, you literally have the tools to see it all. So the question I'll leave you to chew on is this: how are you going to step up and integrate these advanced peripheral techniques into your very next patient exam? Thank you so much for hanging out with me for this explainer, and keep expanding that field of view.